All right, why don't we get started? Good morning, everybody. Welcome to this week's Cancer Center seminar. It's my pleasure to welcome Dr. Liz Pluhar, who's here from right here at the University of Minnesota, the College of Veterinary Medicine. Liz received her DVM at Oregon State University and then did her PhD at the University of Wisconsin in Madison, and originally started her independent career at Colorado State University as an assistant professor there, but looks like she quickly moved to the University of Minnesota in 2003 as an assistant professor in the Department of Veterinary Clinical Sciences and is currently a full professor in that department here at the U. When I talk to students about some of the advantages of having what we call a comprehensive academic health center, I think about Liz's work because there are very few places in the country actually where you have all of the health professional schools on one campus. And that really provides opportunities for synergy and interdisciplinary collaborations that aren't possible when those schools are kind of spread out. And I think Liz has kind of capitalized on that opportunity by beginning her collaborations with John Olfest with regard to preclinical testing of tumor vaccines and brain tumors. And she's really utilized the canine model as a system for really testing those kinds of unique therapies. And she's continuing that work now, and recently was awarded an NCI Cancer Moonshot Grant to kind of continue that work, and I think that that's what she's going to kind of give us an update on today. So, Liz, thank you.
Thank you very much. I'm really honored to be here today to speak to you guys about what actually led to getting this funding, this NCI funding, which was pretty fantastic to get. They only awarded 5 of these translational grants in the United States, and we were fortunate enough to get one of those grants, and it will really help us to continue the work that was started with John Olfest. Oh, this one. Okay. So these are my disclosures. The funding for the current grant is up there, and then the preliminary studies that I'm going to talk about today that led to being able to get that funding are listed below that. And so we've been very fortunate to get quite a bit of funding to do this work and continue to do so. So the reason why we do it is because of glioblastoma being such an awful disease. It is the most common primary intraaxial tumor in people, and it still has a terrible prognosis. There's been very few major advances in the treatment of glioblastoma in many, many years. The biggest advance was when people started to add temozolomide, which is an alkylating chemotherapeutic agent, to radiation therapy and increase the median survival time by 2 months. And people got really excited about moving from 12 months to 14 months for median survival time. So there's definitely new therapies that are needed to treat people with this terrible disease. And most of the preliminary studies that were done to look at new types of therapy were done in mouse models. So these are primarily induced models of a brain tumor. And the unfortunate thing, it's very nice to use mouse models. We still use them. Mouse models have been used for preliminary data for all the work we've done in the dogs. But unfortunately, the majority of treatments that are tried and are very successful in mice, you can cure a mouse of brain cancer. When that type of therapy has been tried to be translated to human patients, it doesn't work in about 90% of the time. So we think we need a new model. And the model that we're using is our pet dogs. There are certain breeds of dogs that tend to develop intraaxial tumors, high-grade gliomas. And those are the short-nosed breeds, the brachycephalic breeds like the Boston Terriers, Boxers, and Bulldogs, all types of Bulldogs, including French Bulldogs and English Bulldogs. The interesting thing is that there's almost no information about how to treat dogs with these tumors in the literature. And so there's definitely no standard of care. Most of the time when dogs are diagnosed potentially with a glioma, it's through an MRI. And then the most common treatment is to do radiation therapy without getting a biopsy. So you don't actually know what you're treating. And if you look at the literature and see what the median survival time is or the response to therapy for radiation therapy, it's just usually for a brain tumor. It could be a meningioma, it could be a glioma, it could be an infarct, it could be an inflammatory disease because they've never done a biopsy and they just kind of lump everything together. So we've decided to try to use the pet dogs with brain tumors, with gliomas, getting a biopsy so we know exactly what we're treating as a translational tool to look at new therapies. And as was said, we started with John Olfest, and he was really intent on trying to use immunotherapy to treat these brain tumors. So cancer immunotherapy in general is much more directed type of a therapy than chemotherapy or radiation therapy, which tends to affect any rapidly dividing cell in the body, and then some that aren't even rapidly dividing, and just going off like an atomic bomb in your body and just eradicating a lot of different cells. Whereas immunotherapy is trying to target your specific type of cancer cell and only that cancer cell so that you spare the rest of the adverse effects to the rest of the body. And so that's what we were kind of trying to focus on. But there are challenges to using immunotherapy in the central nervous system for central nervous system tumors, because the central nervous system has the blood-brain barrier that tries to prevent inflammation occurring in the central nervous system. You don't want to always be dealing with meningioma or meningitis or encephalitis all the time, and so there is this barrier that prevents that from happening on a regular basis. And so there's very few normal immune cells in the brain, and so if you're trying to stimulate immunotherapy in the brain, you have to get across the blood-brain barrier, and that is one of the reasons why the checkpoint inhibitors that are commonly used for many, many cancers don't really work well in glioma, because they are monoclonal antibodies and they don't cross the blood-brain barrier. So what we wanted to develop as the Minnesota paradigm was to use a vaccine-based immunotherapy, which is kind of shown here. There we go. So this is kind of a standard. Somebody is diagnosed with a tumor. The tumor is removed. They remove blood cells to try to isolate monocytes, peripheral monocytes. Those are cultured in vitro, trying to generate some dendritic cells to get immature dendritic cells, and then they are exposed to the antigen, the tumor antigens. They're maturated to become mature dendritic cells that recognize those tumor-specific antigens, and then those are returned to the patient. That takes a long time. It's very expensive. And so what we were trying to do is do dendritic-type vaccines without needing the leukapheresis, the cost and the time to do the leukapheresis. And so we were just doing injections, local injections, to stimulate the immune system peripherally. So this is one of the things that John Olfest worked up with me. Not only was he one of the first people that decided that pet dogs should be used as a model, but we also started doing these vaccine-mediated immunotherapy. So this is an MRI of a dog with a very large glioma in its frontal and olfactory lobes. So this is normal brain back here. This white is the skull, and this big white enhancing mass here is the tumor. So we go in, Matt Hunt and I go in and we remove the tumor, and then we send some of the tumor off to for histopathology, so we get a definitive diagnosis as to the tumor type and grade, which we feel is a really important thing to do to know what you're treating. Then the rest of the cells are sent to the laboratory where they're expanded in vitro in neural stem cell medium. Those tumor cells are lysed by repeated freeze-thaw cycles and then irradiated to make sure there are no live tumor cells. And what that does is produce these tumor-specific antigens for that specific dog. This is very personalized medicine for these dogs. And then it's the antigens are mixed with some sort of an immunoadjuvant, usually some sort of a TLR agonist. We've used several different ones. Those are then injected into the body to try to activate the local dendritic cells in the skin. And then those dendritic cells go to the lymph nodes to interact with T cells and then create an immune response. And those immune cells then circulate around the body and hopefully get into the brain as well to monitor for the tumor. So the first grant that we got was one from the American Cancer Society. And we were interested. John had done a study with Mike Olin, and they had looked at mice, treating the mice with the vaccines versus vaccines plus interferon gamma gene therapy. And the mice, the life expectancy in the mice, the response to the therapy was greatly improved by adding in the interferon gamma. So we decided to try that in dogs. So one group got just the vaccines, and the other group got vaccines plus intracerebral injections of an adenoviral-mediated interferon gamma. And we used cultured the cells, as I mentioned earlier, and then used CpG-ODN as our adjuvant, immune adjuvant. And then the interferon its primary focus was to try to recruit natural killer cells to the brain to help that immune response in the brain. This is the timeline of the study. So we would do the surgical resection plus or minus the interferon gamma gene therapy at the time of surgery. The dogs would get a series of 6 vaccines starting about 2 weeks after surgery, and then once every 2 weeks for a total of 6 vaccinations. We would collect blood at regular intervals and also do an immediate post-op MRI to see if there was any residual tumor, so we'd know what our starting point was as far as tumor load. And then we did serial MRIs at 3, 6, and 12 months to look for any tumor recurrence. So this is a really, when we started doing this, very few people operated on intraaxial tumors in dogs. And so I had no idea how this was going to affect the dog, how they were going to do. And so it was a little bit of it was a huge leap of faith, actually, especially for the owners of the first dog named Batman. We got a lot of press with Batman, but he was the very first dog that we treated, and that was back in 2008. And it turns out that these dogs do great. I mean, they're not offered any treatment usually, and so we were offering owners a little bit of hope because we said, we don't know what's going to happen, but we're at least going to remove the tumor and then hopefully stimulate a response and increase the survival time. Because if you don't do anything to a dog with a glioma, the median survival time with no therapy or just palliative therapy alone is about a month, maybe 2 if you're lucky. And so it's a very, very short life expectancy in these guys. Well, it turns out that these guys recover from surgery very, very quickly. They're usually up and running around. I'm taking them outside for a walk within an hour or 2 of waking up from anesthesia. I think they have a headache because they've got this mass effect in their brain. And when we remove the tumor surgically, we relieve that increased intracranial pressure, and they wake up feeling like $1 million. The headache they've had for a couple of months is gone. So they're like, yeah, I'm going to go run around outside. And they do. They do really well. And we try to tell an owner whose dog has been given this grave prognosis of a glioma that I'm going to do brain surgery on your dog, and then they're going to be out and running around within an hour or 2 of surgery. They usually don't believe me until they actually see it. So, and just for a demo, this is not an hour after surgery. This is about 4 days after surgery. This is a little dog whose owners brought Juno from North Carolina for us to treat. And you'll have to notice the little toy. It's a little Minnesota gopher. So that's Juno, who is a typical breed, a Boston Terrier that had a high-grade glioma removed. And she's running around and playing with toys a couple of days, within a day of this. I think that was the day that they got home from the trip. So unfortunately, for this study, what we found was, we really expected to hit a home run and just have a really, really years of survival for these dogs after treating them with our immunotherapy. But it wasn't a home run. It was maybe a double. But the interesting thing was that the addition of the interferon gamma to the vaccines made absolutely no difference in the median survival time. So these two curves are not significantly different. So we've got the dogs that got the interferon gamma in red and the ones with just the vaccines in blue, and the median survival time is about 7 months maximum in these guys. So definitely not a home run. And all the dogs were dead by 8 months. Interestingly, we found that some of the dogs actually had low-grade gliomas that were enrolled in the trial. We weren't doing frozen sections at the time, so we didn't get the diagnosis until after the dogs had had surgery a couple days later, after my pathologist had looked at the biopsies. And we decided to go ahead and treat these guys. And it turns out that, similar to people, dogs with low-grade gliomas have a much better prognosis. And you can see the median survival time for the treatment, whether they had the interferon gamma or not, was a couple of years rather than a couple of months. And so and there's one dog who's currently still alive down in Florida that we originally thought it was a high-grade glioma, but when they went back and looked at the biopsy again after I said, this dog is out years now and it's still alive, and so my pathologist went back and they said, yeah, maybe there's not really a lot of hallmarks of a high-grade tumor here, so maybe that's not what's going on here. One of the things that we also found was that Batman was the first dog that got the interferon gamma, but we had used a human interferon gamma gene, and we created a canine interferon gamma, and the next dog we treated, we lowered the dose a little bit that we gave, but that dog had severe toxicity in the brain from injecting the interferon gamma, so we had to lower the dose again from that. When I was thinking about whether or not why the interferon gamma really didn't help, I said, I'm really not sure whether or not the cells were transfected with the adenovirus, but I know that this dog was affected. There was a lot of transfection that went on because this dog was really severely affected. So I think that I don't know why the interferon gamma didn't help as we suspected and as it showed in the mice, but one of the things that another thing I got from that study was that maybe dogs are a much better model, and that what happens in mice doesn't translate to people. It may not also translate to dogs. So that was our first foray into treating dogs with high-grade gliomas. The next study that we had funded was a collaborative study with Maria Castro, who was at the time at UCLA, and she's now at the University of Michigan. And they were more interested in doing intracerebral gene therapy with a combination of genes to stimulate an immune response locally. And so this was a double-blinded study where the dogs got some sort of an intracerebral injection. It either had beta-galactosidase as a reporter gene, and the dogs that got treatment were treated with, I keep pressing the wrong button. Were treated with FLT3 ligand, which promotes dendritic cell differentiation or antigen-presenting cell differentiation and expansion into dendritic cells locally in the brain. And then those cells, those dendritic cells, were able to process the tumor antigens that were produced locally by the other gene, which was a thymidine kinase, which acts as a suicide gene. So the gene coding for the thymidine kinase is incorporated into the tumor cells. And when you give a non-toxic prodrug, ganciclovir, it is triple phosphorylated by the thymidine kinase gene and causes cell death. And then there's also what's called a bystander effect, where it will kill cells that are nearby that haven't been transfected. And so again, these dogs were diagnosed with a glioma based on the MRI characteristics, and then we would get the definitive biopsy after surgery or during surgery and then looked at by the pathologist. So we went in to do surgical debulking. We always tried to get gross tumor resection, but it wasn't always possible. But we did as best as we could, and then after we debulked the tumor, we injected the vector around the resection cavity. So we just kind of stuck a needle into the tissue around the resection cavity and injected the amount of liquid that contained the right concentration of the advirus. And we had two dogs in the treatment group for each dog in the control group, because we felt that this wasn't going to do a whole lot. And then we also treated all of these dogs with temozolomide, the alkylating agent temozolomide. We actually wanted to do radiation and temozolomide just like they do in people, but when we realized that most of the dogs were coming from all over the United States for treatment, it just wasn't feasible for people to leave their dogs for a month to be treated when we had no idea whether or not they were going to live beyond that month. People weren't going to really want to leave their dog with us for the last days of their lives. So we just we took out the radiation, but we kept the temozolomide. And so this is the treatment, how the treatment went. We did surgery, gave the gene therapy either with the beta-galactosidase or with the combination genes. We would give doxycycline because these were TET-on genes. So by giving the doxycycline, we turned the genes on. We gave ganciclovir, which is the prodrug for the thymidine kinase for the first 10 days after treatment, or after surgery, and then we gave the cyclic or a low-dose temozolomide for 28 days, and we stopped for 28 days, and then we gave cyclic high dose, which is similar to what they do in what's given to people that are treated with temozolomide. So we actually recruited 15 dogs, 10 in the combination therapy group and 5 in the control group. Turned out that 2 of the tumors were anaplastic meningiomas, and so those dogs, there is one of those dogs that was treated in 2010 who's still alive. So meningiomas, even anaplastic meningiomas, are very amenable to gene therapy treatment after surgery. These mean age was about 8 years, which is fairly typical. And you can see that we had a variety of different types of high-grade tumors. There were some glioblastomas, some anaplastic astrocytomas, and then anaplastic oligodendrogliomas, and then a single PNET, or primitive neuroectodermal tumor. Easy to say. And there was one dog that actually we were unable to recover from anesthesia, and that dog was not mentally appropriate when we started the surgery, and so I don't know exactly what happened with that dog, but he didn't survive surgery. We didn't notice any adverse side effects of the surgery itself or of the gene therapy in these dogs, and then a couple of the dogs had a little bit of nausea or inappetence after getting temozolomide, and so we treat with an anti-nausea agent. So 5 of the dogs that were treated in this group actually had tumor recurrence, and they had prolonged survival after getting another therapy. They were either recruited into another study or had radiation therapy afterwards. So, and that was 4 dogs from the treatment group and 1 from the control group. So when I looked at the overall survival data, I didn't want to include those dogs, and I thought it was better to look at the progression-free survival time rather than the overall survival time, because when you treat a dog again, it's obviously going to affect the overall survival time if they respond to that second treatment. And all the deaths in all the dogs in the study was due to tumor recurrence. So although we are prolonging these dogs' lives, they do eventually succumb to the tumor. So this was a real typical case. Again, a boxer, one of those brachycephalics, 8 years old, with a GBM. This is the pre-op MRI showing the tumor right here in the temporal lobe. This is our immediate post-op MRI showing what we consider to be complete resection of the tumor when we looked at all the different sequences. This is 2 months after surgery during treatment, and we see it looks like we still don't have any disease, so no evidence of disease. And then, but 6 months later, or 4 months later, at 6 months after surgery, we see that the tumor has recurred in the same location, and it also had spread from that location a little bit locally. And again, these dogs, here's this particular dog, playing outside, playing on the deck in Florida with its ball. So they have a really good quality of life, even though we're not curing them of this disease by any means. And here's the survival curve for these dogs, the dogs in this particular study. The red line is the dogs that actually got the therapy, and the blue line is the dogs that got the reporter gene. This represents one of the dogs that did have more therapy, so it had tumor recurrence at 104 days, but then it was recruited into the vaccine, one of the other vaccine studies, and ended up living much longer. Oh, it ended up living 104 days after it had recurrence at 61 days and then lived 104 days. And then these are the dogs in the treatment group, the 4 dogs in the treatment group that had other therapy. This is when the tumor recurred, and then this is how long they lived after some other therapy. And there is, although it looks like there may be a difference in the progression-free survival time between these two groups, 166 days versus 61 days, when you do statistical analysis of this, there's no significant difference. I think that that may be a power issue, and if we had had more dogs in the study, that we may have seen a significant difference between the treatment, the temozolomide versus the gene therapy group. But these, although these are much less expensive to do, trials to do in dogs than they are in people, they're still expensive, much more expensive than doing mice. So if we 10 dogs in a group, we consider to be a pretty good number. So problems with the intracranial gene therapy, Dr. Castro, when she treated the mice, they didn't do surgery in the mice. They used a stereotactic frame, and they would put the needle in and just inject into the tumor, the gene therapy into the tumor. And so they injected slowly there over time, over about 5 minutes, and then they left the needle in place for another half minute, and then they would pull the needle out to try to leave as much of the gene therapy at the tumor site. Since we were injecting all around the resection cavity, if we did basically 6 minutes for each injection, that would add a couple of hours to our surgery. So, and plus I was holding the needle and Matt was injecting, and my hands are fairly steady, being a surgeon, but they do move around, and you can imagine the tip of the needle in the tumor going, back and forth, standing there for 5 minutes. So yeah, we didn't do that, especially when we had to do about 20 injections around the resection cavity. So we just injected and hoped it stayed where it was supposed to be. Yeah, so there's that needle. But we never did. Never went back and got a biopsy shortly after the surgery to see whether or not we had good transfection and good distribution of the gene therapy around the resection cavity. And Dr. Castro actually has the brains of some of these dogs, and I haven't gotten the results of whether or not they saw anything after the dogs died, but I don't expect that they would see anything at this point anyway. The other problem is that temozolomide is a chemotherapy agent that can be inactivated by an enzyme, and so there are some gliomas in people that are kind of resistant to this alkylating agent, the effects of the alkylating agent. And we never did test the MGMT status, this enzyme status in the dog, so we don't know whether or not the temozolomide actually helps the dogs. So there are a lot of things that can affect the immune response, and Dr. Olin worked with Dr. Olfest on several of these things, and found that the oxygen tension at which you grow the cells is very important, and you actually get a different type of an immune response if you use a vaccine with cells that are grown at 5% oxygen versus atmospheric oxygen or 21% oxygen. And so we decided to only use cells that were grown at the 5% oxygen for the vaccines. And then the other thing that was found is that we were injecting these dogs on the back of the neck because you figure you want to have your immune response as close to the brain as possible. But Dr. Olin published a paper that showed that the closer the vaccines were given to the head in mice, the poorer the immune response. And so and that led to a discovery that there are immunosuppressive agents that are being produced by the brain tumor that will suppress an immune response in the local draining lymph nodes. And I'll get more to that in just a minute. But so we were trying to figure out how to enhance the immunotherapy. And so we were only using cells that were grown at 5%. We decided to forego the intracranial gene therapy because we weren't sure if we were being efficacious in doing that. And then we also looked at adding OX40 ligand to some of the dogs in the treatment group to help to stimulate more of an immune response. And then in this particular study, Dr. Olfest wanted to have a surgery-only group, and I didn't feel comfortable doing surgery-only because there's very little that's published about dogs that have had surgery for glioma only. But the 1 or 2 dogs that there's information about, it didn't extend their survival time at all. They lived for a month or 2. So it's the same as if you do nothing at all. So I said, if we're going to have a control group, I want to do something, even though we don't know whether temozolomide alone is going to help, I feel more comfortable doing that. So we had temozolomide that was added in there for the control group. And we basically did the same thing. Dogs were diagnosed based on the MRI. We did surgery to debulk the tumor, and then they were randomized into the different treatment groups and got the variety of treatments. And so there were some dogs that got temozolomide only. There were 4 in there, but 1 turned out to have a tumor other than a glioma, so we had to censor that dog. And this is a black line, so you can see that they didn't do great. And then dogs got different combinations. Here's OX40 ligand with the temozolomide, the vaccines with the temozolomide, vaccines with the OX40 ligand, and then all 3 vaccine OX40 ligand and temozolomide. And again, these look like they're different, the median survival times, but statistically there's no significant difference among the groups. And again, it's probably a power issue because there were so many groups with few dogs in them. Some of the treatment groups to me don't make sense now, and I realize that these treatment groups were designed by Dr. Olfest about the time that he was got very ill from his melanoma, and so. But I guess it's interesting to look at that even though we're doing these combination therapies, it really didn't help increase the survival time in these dogs. So what we needed to figure something out that would help us to try to really increase the survival time. One of the really significant things that we found was that the French Bulldogs, we didn't treat a lot of them, but for some reason, French Bulldogs simply did not respond at all to the immunotherapy. The median survival time was only 55 days in the French Bulldogs that we treated, and the median survival, which is much shorter than 8 months, which was what we'd found in the other dogs. And so one of the exclusion criteria is now French Bulldogs, so I won't treat French Bulldogs in any of the immunotherapy trials. And I'd like to try to figure out why they're different. What's different about the French Bulldog? Is it something with their immune system? Is it something with genetics? I don't think the genetics of the French Bulldog are that different from the other brachycephalic breeds, but it's something that I'd really love to be able to figure out before I retire. So basically what we've realized at that point was, by this time, and this is over several years and several different studies, is that there really isn't a big difference in the dogs that have these high-grade gliomas, unlike people. So there are definitely survival differences in people that have a grade 3 glioma, say an anaplastic astrocytoma or an anaplastic oligodendroglioma versus a glioblastoma. And we didn't see that in the dogs. And I think one of the reasons for that is that we're diagnosing these tumors very late in the dogs because they can't tell you I've got a headache or they don't have some of the more subtle symptoms that a person would have. And so we diagnose these when the dogs start having, in most cases, grand mal seizures. So they'll have grand mal tonic-clonic seizures. At that time, there's something going on with your dog that's not right. And they'll take the dog into the doctor, to the veterinarian, and usually that's when they'll do some sort of an imaging of the brain and realize that there's a tumor there. And so these tumors can be quite large relative to the total volume of the brain. And Brian Anderson did a very quick and dirty study of that, looking at tumor volumes to total brain volume in people versus dogs, and found that it's about 4 to 5 times larger in dogs. So these tumors relative to the total brain volume was quite a bit larger than and bigger than in people, which definitely is going to affect, 1, your ability to completely remove the tumors, and 2, they're probably more invasive at that time. I think the longer they're there, the more invasive they're going to be. And again, it was interesting that we never saw a big difference in either the progression-free survival time or the overall survival time in these dogs if they were not offered any more treatment. So once the dogs started to go downhill and had tumor recurrence, they tended to be euthanized, which is another problem with using overall survival time, because these dogs very, very infrequently die a natural death. The owners have the choice of euthanizing their dogs when their quality of life is no longer any good, which doesn't happen in people most of the time. And so the overall survival time in dogs isn't a real overall survival time. It's skewed because of the ability of the owners to do the euthanasia. But it was interesting that no matter what we did, we just couldn't really seem to get beyond that 7 to 8 month time frame for overall survival time in these guys. And we are still doing some immune monitoring, like figuring out what's happening in these dogs that were in these different studies, and also looking at what went on in their brains. Because luckily, most of the owners that allow their dogs to be treated in these studies are very good about following up, and also allowing me to have the dog's brains at the end of the clinical trial. And so we have these brains to look at, and my pathologists work really hard at getting this done. But it was time to move on, and a lot of the work that Mike Olin has done is looking at how glioblastomas actually will cause immunosuppression in the body. And this is a cartoon that's showing some of the ways that it does that. And so I'm not going to go into detail because I don't have enough time, but there are many, many mechanisms by which the glioblastomas will actually suppress a normal immune response in the brain, both in the tumor microenvironment, so in the immediate microenvironment, and then also in the draining lymph nodes as well. And so we were trying to figure out how to overcome this immunosuppression by the glioblastoma. And Dr. Olin realized that there is a protein called CD200, also known as OX2, that is expressed on a lot of different tissues, including normal brain tissue. So this is a normal brain, CD200 staining of normal human brain tissue. And so the stain is this gold color. So normal brain cells, normal brain, the neurons and the astrocytes in the brain are expressing CD200. And I think that's to modulate, this is a checkpoint type, it's kind of a checkpoint inhibitor. And so it's modulating the immune response in the brain. It's not allowing a lot of inflammation in the brain, which, again, as I said earlier, you don't really want. And then it's interesting because the receptor for CD200 is only expressed on immune cells, different types of immune cells. And what we found is that when the CD200 binds to its receptor on the immune cells, it actually inhibits an immune response. And so ligation of that receptor will suppress an immune response. And what he looked at, one of the things he looked at was soluble CD200, so CD200 that was cleaved from the tumors and was in the serum. And in people, they looked at changes in the serum CD200 levels, or the soluble CD200 levels, and found that the CD200 levels were decreased, and then over time, when the tumor started to recur, those CD200 levels would increase again. And so he was trying to find a way of suppressing the CD200, or modulating the CD200 immunosuppression. So this is a little cartoon that kind of shows what happens. So we've got the CD200 on the tumor, the whole native protein, and it becomes solubilized, and then it binds to an inhibitory receptor on the immune cell. This is an antigen-presenting cell, and causes a downstream signaling response that will actually cause immune suppression, or suppression of immune-related genes. And what we think is happening is that some of these CD200 native molecules are cleaved into smaller peptides that will then bind to another set of receptors that are on the antigen-presenting cells. But these, when the peptides bind to these receptors, they actually will activate an immune response or stimulate an immune response. And interestingly, the activation of the immune response can override the immunosuppression by the CD200 binding. So it's, we're using in dogs, this is the native CD200 protein, and we're using a peptide that's based in this area of the molecule. This is the peptide sequence, and so this is the one that we, Dr. Olin thought would be the best one to use based on some murine studies, and Dr. Pinella as well was working with us on this, and looking at what sequences, peptide sequences, would bind the best and give us the best response. And so we did a pilot study that was primarily funded by the Humor to Fight the Tumor. And we decided to try to improve our immune response in the dogs getting the vaccine by adding in the CD200 peptide that would allow us to hopefully have a more robust immune response. And then we also decided to give boosters of the vaccine. So instead of stopping the vaccines after a series of 6, we decided to keep trying to stimulate the immune system by giving boosts every 6 to 8 weeks to these dogs. And we had some pretty, what we feel is our pretty amazing response. So the first thing is that we actually, for the first time, really saw something going on in the brain in response to the injections, to the vaccines that were given outside of the brain. These are just injected into the skin on the back of the dog's, on the back of the dog's neck. And what we saw was this is an immediate post-op MRI, and this is after getting a series of the vaccines. And the tumor was actually over on this side. You can kind of see the break in the skull where we did our craniotomy. And we saw this T2 hyperintensity that didn't null on flare after several of the vaccines. And when these dogs actually had symptoms of CNS inflammation. And what we found is if we treated that CNS inflammation with high dose of corticosteroids, the inflammation went away. Unfortunately, in this dog, we also stopped the vaccines because I really wanted to get rid of the inflammation since the dog was so clinical for that. So we gave the steroids, stopped the vaccines. The inflammation went away, or this infiltrate went away, but the tumor also recurred. Then we treated this dog again with more vaccines, and the tumor regressed a bit. So that was one episode of seeing tumor regression. And this is another dog that had a bilobed tumor. And after we did the surgery, we realized that we left a lot of tumor behind. Down here, this is our one resection cavity, and we basically left half of the tumor behind. And we didn't go back in and remove more tumor. We just treated with the vaccines with the CD200 peptide. And this orange is the immediately after surgery, and then this is after 4 months of treating with the peptides. And you can see that the tumor volume is less. And the yellow is outlining the lateral ventricle because they're both T2 hyperintense here. But the tumor wasn't gadolinium enhancing, and so you could see it best on the T2. So this is just outlining the ventricle, and then this is tumor, and this is after treatment. Ventricle's here, and the tumor is smaller. We had never seen tumor regression prior to using the CD200 peptide. And so similar to people, we also found that if we looked at the soluble CD200 in the serum, this is a dog named Marley that I treated. He had elevated levels, and then they went down after surgery and during therapy. And then at 1 year, we did an MRI, which is shown right down here. This is our 1-year MRI. The tumor had been right here. There's no evidence of disease. And I've gone back and I've looked at this, and I looked at this, and the dog was doing great. But the CD200 level was quite high at this time. Well, 4 months later, the dog started having breakthrough seizures. We did another MRI, and you can actually see that the tumor recurred. And so what I think that the elevation in the soluble CD200 may be a biomarker to know that this tumor is starting to recur, and we may want to do an MRI before 4 months, because this tumor, this is quite a bit of growth in 4 months' time. So if we'd done another MRI a month later, knowing the CD200 levels were elevated, we may have been able to prevent this severity of recurrence. So this is our survival curves comparing the tumor lysates alone versus the tumor lysates with the CD200 peptide. And the one with the peptide is in red. And although it looks like all the dogs are dead, the little black marks are actually dogs that are still alive after therapy. And so there are several dogs that are out there. And the median survival time has actually is just about a year right now versus 7 months. So it's almost doubled our survival time by adding the peptide. And it may be even longer depending on how long these guys continue to do well without any tumor recurrence. Most of them are, well beyond 500 days and still doing quite well. And we keep in touch with these people, and we're continuing to do the booster vaccines on these guys. So, the fact that I changed 2 parameters in the trial, added the booster vaccines and added in the peptide at the same time, kind of confounds us. So I don't know whether all of this is due to the CD200 peptide or some of it's because we're doing booster vaccines, and we probably should look at that at some time. But I'm just happy that it's working well at this point. So these are the studies that led into us getting the U award from the NCI. And so what we're doing is we're looking at, we're doing a combination of things. We're using the therapy that Dr. Olin helped develop, using the checkpoint inhibitor, the CD200 peptide, along with vaccines in one group of dogs. And then in another group of dogs, we're doing the gene therapy that Dr. Maria Castro developed with the combination immunotherapy. They've been working to try to increase the efficacy, the response to their vaccines by changing their adenovirus and then changing the gene therapy a little bit. And they feel like they're getting a better response than the one that in the rodent models that they're doing. And it's improved from what they had seen prior to the previous study we'd done with them. And then we're also excited to try to add the CD200 peptide in with the gene therapy. So those will be the 3 treatment groups. We also want to look at whether or not the CD200 is a way of looking of a biomarker for disease recurrence. And then we want to look at the effects of this combination immunotherapy. So just really quickly, the inclusion criteria are just that the dog has to have a solitary mass, intracranial mass that looks like a glioma. And then we confirm that with our histology. Dogs have to have normal mentation at the time of surgery. I do have realized that I've done a couple of emergency craniotomies for dogs that were semi-comatose, and those dogs don't do well in the long run. So they have to have fairly normal mentation at the time, informed consent by the owners, of course, and then it has to be a surgically resectable tumor. So if the tumor is in the thalamus, you don't want to operate on the thalamus, so that a dog with a thalamic tumor would be excluded from the study. As I mentioned, French Bulldogs can't be in the study. They can't have any prior definitive therapy. If they have severe concomitant disease that may prevent them from surviving for the year that we want them to survive for the study, they're excluded. And then if they have uncontrollable seizures, we can't have dogs that, because most of the times owners will euthanize their dogs if they can't control the seizures. Again, we're basically following the same kind of therapy that we did in the past. We originally were going to do chemotherapy in all dogs like we did with the previous study. However, I've talked to a couple other people that are doing some canine brain tumor therapies, and they've looked at the absorption of temozolomide in dogs, and it turns out that you can't give enough oral temozolomide to actually get therapeutic serum levels in the dog. We don't know why, but you can't. And so I talked to the people at the NCI, and they said it was okay if I just excluded the temozolomide from all the treatment groups, which I'm happy to do because it's saving me buco bucks. It's a very, very expensive drug. They're going to be randomized into 3 treatment groups. We're doing the physical exams, neuro exams, quality of life at each vaccine and each MRI appointment, and then we're doing the MRIs immediately post-op, and then 4, 8, and 12 months, and following these dogs until their death or euthanasia. These are the just treatment groups. We're doing the tumor lysate with the TLR agonist and the CD200 peptide. This is kind of the timeline for that. And these are the two dogs that are the two groups that are going to be getting the gene therapy, the thymidine kinase FLT3 ligand gene therapy. This is one of them. They're going to be getting the CD200 vaccines, and then the other, they're not going to be getting the CD200 vaccines. So I think these may be the same. Oh, no, the CD200 vaccines are, so they're just going to be getting the CD200 peptide and not the vaccines themselves, not the tumor lysate vaccines. And then we're going to be doing a lot of different immune monitoring. This is in collaboration with Dr. Castro at the University of Michigan. So we're going to be trying to figure out what type of immune response we're actually inciting by doing these different therapies. And then we're also going to be doing the histopathology, doing just hematoxylin-enusin staining, getting a diagnosis, and then doing a lot of immunohistochemistry to try to get a little more information about these tumors. And then we also want to do some transcriptome analysis on these tumors as well, which hasn't been done in the past. These are my collaborators on the new trial, both here at the University of Minnesota and at the University of Michigan. And with that, I'll finish. Just a little longer than I was supposed to, but thank you very much for your attention today.
All right, do we have any questions or comments?
Great talk, Liz. I have two questions. The first one has to do with something you mentioned really early on about the human gamma interferon not having much of an effect. Do dog cells respond to it? Does the dog gamma interferon receptor bind human?
No. That's why we switched. We no longer, we treated the first dog. We treated Batman with that, and then backwards, but then we did the binding, and it didn't. So that's why we developed the canine interferon.
Okay. Okay.
Yeah.
All right. And then the second question has to do with the soluble levels of CD200 for use as a biomarker. Mm-hmm. So your model is that you've got intact protein inhibiting a response, peptide fragments activating a response, and you said that the activation is dominant over the inhibition.
Based on some of the work that Elizabeth actually has done.
So I guess I don't understand why a higher level would correlate with disease recurrence. If so, are you thinking that you're not getting that much degradation, proteolytic degradation, and you're not getting much activation, or so what's the model there? I guess.
So when we're measuring the CD200 levels in the serum, I think it's only the native protein. If I'm not mistaken, it's not the peptides, not levels of peptide. And so since the tumors are, the CD200 is being solubilized from tumor, if there's no tumor that has the CD200 on the surface that's being cleaved, whole native protein cleaved, then the serum levels should drop. And then if the tumor is coming back, the serum levels of the native protein would go up. We haven't measured peptide levels in the serum, and we're not even sure whether these peptides occur naturally. That's one of the things that we're going to try to look at is do these cleaved peptides, do these cleaved CD200 peptides actually exist in the dog or in people?
Thanks.
You're welcome.
Other questions or comments?
Nope.
So I was wondering whether all the dogs that you're treating are purebred? I mean, how do you know there isn't some French Bulldog in some of these dogs?
There's not, pardon me?
Are all the dogs you're treating are purebred?
Yeah.
Or how do you know that there isn't French Bulldog
genome
in some of the dogs?
That's a good question. Most of them they're not all AKC registered, but most of them tend to be fairly purebred dogs. In fact, there's very few dogs that aren't brachiocephalic breeds that I've treated for the high-grade gliomas. There are a few, like I have treated, I'm trying to think, because most of those dogs actually have the low-grade tumors. but I don't know. One, I don't know whether it matters, but
Well, I just wondered if when you're not seeing as good responses, there's something about the genetics of the dog in terms of what exact breed it is and whether it's really purebred.
yeah, yes, that's a good comment. I hadn't really thought about that because most of the dogs that I do see are they're a box, they're boxers or they're Boston Terriers or they're French Bulldogs. Whether or not they come from the same lineage, so it's possible.
I just wondered, is there something about the genetics of the tumor that's different depending on the breed?
I've been trying to get funding. Yes, I would love to know that.
And do you even know what some of the common genetic abnormalities are? Do they have the EGFR amplification with the
So
V8?
there's been very little analysis done in the canine tumors, and I have such a stock of these tumors. I've got the fresh tumor that's frozen from all of the dogs. I've got recurrent tumor in their brains. We've got tumor on sides, and I have been applying to get funding to try to look at this. And I've been unsuccessful for 3 years. I don't know why. I don't know why there's not the interest in, because I think that's really important. There's very little that's been published. Some people have done some looking at molecular signatures of the canine tumors, but and there are some similarities between canine tumors and human tumors as far as their molecular signatures. But then there are other important things like I'm just having a complete IDH. So the IDH mutations that are really common in human glioblastoma, or a lot of human glioblastoma, they haven't seen that in the canine tumors. However, very few canine tumors have been looked at, so it just may be, because it's not 100% in human tumor, so it just may be a numbers game where the more we look at, the more similarities we'll see. But aside from the genomics of the tumor, it seems like dogs are more prone to develop oligodendroglioma, tumors of the oligodendrocytes, rather than the astrocytes. So we see a lot of anaplastic oligodendrogliomas, and they're not as common in people. GBMs are much more common in people. But a lot of these tumors have mixed components. They have glial cell components and oligodendrocyte component to it. So, and in people, I know if there's anything that looks GBM, like a glioblastoma, they call it a glioblastoma, even if there's some oligodendrocyte cells in there. So, and they don't, our pathologists are not looking at the same criteria as the people that are looking at the human tumors. I don't know. There's a lot of work that needs to be done, and the NCI is very supportive of funding work in that direction. So whether we do the work here or whether I just supply them with my tumors, it doesn't really matter to me, but I just think it's a really important work to get done.
Very good. Any other questions or comments? Thank you so much.
Oh, you're very welcome. Thank you.